sexual and intellectual. There's a direct relationship with their ADLs. Now, delirium is a big one. Delirium, you'll see that a lot too on ATIs, NCLEX. I'm pretty sure they would have it on ATIs. So there seems to be a lot of delirium questions. So you'll want to know that for the future also. And a big take-home point. Delirium, it's always secondary to another condition or substance abuse. You don't just have delirium, it's secondary to something else. So, know that. So also, you want to review this well. Delirium is a state of mental confusion that develops quickly and usually fluctuates. So it is acute. It doesn't come on over months of time. They're disoriented, incoherent, and have memory disturbance. But it has comorbidity. It always exists secondary to another medical condition. For instance, a UTI, substance abuse, or might be multiple causes. Now, why do you think a UTI would cause delirium?
Infection.
Right, and who would be real susceptible to that?
Older adults.
Elderly people. So you always want to, think of an elderly if they're confused, look at UTI. Okay, and then here's another important point. Once the underlying cause is treated, the delirium should resolve. So you're not really treating the delirium, you're treating the cause. And it is misdiagnosed in 75 to 80% of people. Whoops, there's one more. It's present in 60% of nursing home residents who are 75 years of age or older. So why would that be, do you think? Maybe they might have UTIs. But it's not their main disease. Okay, now, so it's more common in older people. Could it be in children? Yeah. Could you have delirium in children? When do you think that might be? Fever. A high fever. Usually young children with a high fever. But children can have it, but just know that it's more common in the elderly, okay? Okay, so here it is again. It occurs more often in older adults. And box 18-1, page 272 is written right here. Another common cause is surgery and drugs. Surgery. Why surgery? Right, right. And who do you think is going to be more at risk? Elderly. Right. The anesthesia, sometimes they're very confused for weeks. I've seen some elderly people who were perfectly fine and they had come out of anesthesia after surgery and they have to be put on the psych ward.
It's because their body doesn't filter it out, the kidneys and all.
Right, exactly. So they're at greater risk. And then drugs could cause it too. Infection, which could be a UTI, hypoglycemia. When you get hypoglycemic, you might have a little delirium. Fever, like I said, and that might be the children. Or homeostatic disruptions. Pain and emotional stress, pneumonia, cerebrovascular disease, and CHF. So be familiar with that. So there's disturbed consciousness with cognitive difficulties. Their thinking's distorted, impaired, and their perception is. Attention disturbances, they can't focus. And then sundown syndrome. We associate that with Alzheimer's, but people with delirium can have sundown syndrome too. And I'm going to talk about this as we go, but if someone has dementia, would their diagnosis also be delirium?
Why not? They have to.
Once they're diagnosed, it's interesting, once someone's diagnosed with dementia, they won't have a delirium diagnosis. Do you know why? Right, exactly. Their dementia won't be reversible, unfortunately. So they wouldn't be classified with a delirium. Yes?
All delirium reversible?
Yeah, if it's not delirium. Right, because it's not permanent. It always has a secondary cause, and you try to treat that cause. Now, you might have a patient who has delirium, and then they find out they have Alzheimer's or dementia, and then that wouldn't be delirium anymore because it's not temporary. You're not going to reverse it. So people with delirium can have sundowners, just like people with dementia. So the clinical picture, again, of delirium, obviously disturbance in consciousness, cognition, develops over a short period. It could be days to weeks. Common in hospital patients, especially older adults. And why? UTI and surgery, things like that. Maybe even medications they put them on. So it is transient. Correct the underlying condition, and then complete recovery should occur. Should occur. So if it doesn't, it's not delirium. Table 18.1, page 273. So it's acute, sudden, sudden reduced clarity of environmental awareness. They can't focus. I think we talked about all that before. Sundowning, disorientation is worse at night and early in the morning. Now, to assess them and their physical needs. I think you would know how to assess them. I think you know how they would be presenting. But what about their physical needs? So they might be wandering, pulling out IV lines, Foley catheters, falling out of bed. So you want to try to get their orientation as improved as you can. So if they need glasses, or they have dentures or hearing aids, it's very important that you make sure they have access to these and they have them. So you'll want to be familiar with that. So if they're laying there and their glasses are over in the windowsill, their teeth are in the jar, and they can't hear a lick of what you're saying, make sure they have all their, what they need, glasses, hearing aids, everything like that. That's page 274, 275. So with delirium, there is autonomic hyperactivity, so their vital signs could be increased. They may be hypervigilant, looking around the room, acting a little paranoid. Labile mood swings, agitation. It could sort of present a little bit like paranoia, it sounds like, doesn't it? So the assessment guidelines, again, determining their level of consciousness, vital signs, risk for injury, you can read over these. And then the diagnosis would be, of course, acute confusion. It could be risk for self-harm, and you can look over these slides. Now the outcome would be that they return to their pre-morbid level of functioning. That would be the main goal. Then of course you want them to stay safe, be oriented to time, place, and person, free of falls. But especially return to their pre-morbid level of functioning. So that means return to how they were before. So know that goal. Okay, now, there's that goal again, return to pre-morbid level of functioning. So there's some outcome identifications here. 4 main ones and to do that, for implementing, I think I'm on a different slide. Let me see. Here's the implementing, okay. Okay, so of course you're gonna ID the cause, but 4 main ones. You want to introduce yourself by name and call them by name every time you talk to them. Even if you've been in the room for 10 minutes, every time you talk to them, say their name. Face-to-face contact is number 2. Communicate in concrete phrases, literal. So very brief, don't go into these long scenarios. And 4, there's those glasses and hearing aids again. Okay, so those 4 ones are very important. Calling them by their name every time, face-to-face contact, brief statements and phrases, and make sure they have everything they need to function. Glasses, teeth, hearing aids. Now, how does this stand out different from schizophrenia? What one thing that you do here that you don't do with schizophrenia?
Face-to-face.
Face-to-face, right. Exactly. So that's all on page 277, table 18.3. Okay, and here we go talking again about the brief statements. Their glasses and hearing aids are there again, using clocks and calendars. Now here's something interesting. Use trained sitters to help with safety. What if they have family? Do you think having family there might be a better idea? Would it make them feel more comfortable?
Yes.
Why would you necessarily want trained sitters? Yes, exactly. The family could be there, that would be fine, but have a trained sitter so that they know how to handle the situation, what to look for, and safety. So be familiar with that too. And that's 276 to 277. Oh, and right over here it says, visiting family and friends must not be held responsible for sitting or watching a confused patient. Use trained sitters to help with safety because they can recognize the signs and symptoms, if things are getting worse or better, and what they should do. So they can make things happen rather than just sit there and watch and then say, oh, I better run down the hall now and get the nurse, I don't know what to do. So the evaluation, of course, remain safe, orient them, identify. There's that return to pre-morbid level of functioning again. The short-term goals would be their vital signs, their skin turgor. Now here's a question. A nurse assessing a patient with suspected delirium will expect to find that the patient's symptoms developed A, B, C, or D. Short period, over a period of hours to days, weeks to months, no relation to another condition, or during middle age. Everyone agree? A. Over a period of hours to days because it's acute, comes on fast. Here's another one. Of the following outcomes, which is most important, most appropriate for a patient with cognitive impairment related to delirium? They will participate fully in self-care from admission on, have stable vital signs 6 hours after admission, participate in simple activities that bring them enjoyment, or return to pre-morbid level of functioning.
D.
Yes, I think you've heard that before. D, there it is. So now with, there's mild cognitive impairment. And with mild cognitive impairment, now this is different than delirium. It's a syndrome where they have mild impairments, but it excludes people with dementia or age-related memory impairment. So people with dementia, Alzheimer's, they would not be considered mild. But that could be someone, say, with mild cardiovascular hardening of the arteries. That could be, you know, just mild. They're not, they can still take care of their ADLs and drive and everything. But approximately 12% of these people will progress to dementia in 1 year. Okay, so neurocognitive disorder major is dementia. So it's more serious, it develops more slowly, it's irreversible, and it's a lot of times from tumors, trauma, infection, toxins. And down here, it tells about the vascular dementia, which would be worse than the mild. And so there's Pick's disease, Huntington's, Creutzfeldt-Jakob disease, Lewy body, and Parkinson's. So this is not really in your book, I don't think, but I just wanted to tell you, this Creutzfeldt-Jakob, it's closely related to mad cow. And do you remember how mad cow came about, where they were feeding cows, other dead cows, they were feeding them meat, and they're not meat eaters? Well, unfortunately, with our meat today, and the way the animals are raised and the big feedlots they go to, everything is corporate. Most of it's corporate. Just big corporations are in charge of our meat, and they go to these food lots, and they're fed all kinds of stuff really they're not supposed to have. And they are finding people, this is becoming more common, and there's a link to that in our meat now, because it's the prions that people come in contact with. So that's probably not in your book, but that's a Miss Levi info, okay? So it's a terrible disease. I even have known people who have had it and died from it. Their brain just goes to mush and disintegrates. Okay, so mild neurocognitive disorder, we said that's excluding dementia. Memory impairment is the main symptom, but it doesn't interfere. Mild dementia is more than one cognitive domain is affected, and it does interfere. That's the two differences there. And I think we should be able to finish. Do you want to finish this up, or wait till you want to finish this up next week? Yes. Okay. We've kind of come to a part where we're going to be getting into a little bit deeper stuff, so I don't want to have to rush over it, okay? All right. So we'll have the exam review 15 minutes before class Monday, but I'll try to remember to send out an email. And I will see you Thursday for